lymphadenopathy with hepatomegaly and splenomegaly. So my patient is Mr. X, 30-year-old male, resident of Balmiki Basti, New Delhi, and a peon by occupation. He presented with fever for 3 months and cough for 3 months. Patient was apparently well 3 months back when he began to experience fever. It was low grade and intermittent with evening rise in temperature. Fever was associated with night sweats, not associated with chills and rigor. It was relieved on taking paracetamol. He also complained of cough, which started 3 months ago. Cough is a...
Can you hold on for a minute? Go back to the
Yes,
previous
sir.
slide. So what else one would like to know about fever here?
Sir, the temperature,
low
if the
grade,
patient documented it.
when you say low grade, what does that mean?
Yes, sir.
Low grade means what?
Sir, temperature less than 103 degree Fahrenheit.
Less than 100 degree Fahrenheit. Okay.
Less than 100.
What is the
And no
normal?
chills and rigor.
No, what
So
is normal? What is normal
so
temperature?
98.4 to 100.4 degrees.
Is?
Normal.
Then why do you say that less than 100 is low grade fever?
No, sir. So not less than 100. It's less than 103 degrees, sir. And not
Less than
associated with
100,
chills and rigor.
less than 103. Where is it written?
So not associated with chills and rigor.
No, that's okay. But where is it written that it is less than 103? No, it has to be
Sir.
at least more than 2-degree variation in baseline temperature.
Okay, sir.
Okay,
Okay,
2
sir.
degree Fahrenheit variation in baseline temperature, more than
Okay,
2
sir.
degrees. But it does not exceed 3 degrees.
Okay, sir.
But not necessarily that chills and rigors may not be there. What else you would like to know about fever?
Sir, any other symptom that is associated with like nausea, vomiting, headache, neck stiffness?
What about duration?
Yes, sir. Sir, basically it started 3 months back and it has been on and off since then.
Okay. And when you say intermittent means what?
For a few hours every day.
So what is by definition intermittent fever? There are 3 types of fever defined.
Continuous,
Intermittent.
intermittent, and remittent.
So what does intermittent mean?
Sir, fever that is present for a few hours every day.
Okay. What is remittent?
Remittent fever, there is a variation in temperature of more than 2 degrees, but it never touches the baseline.
That is remittent or that is continuous?
Sir, remittent, there is variation of more than 2 degrees and never touches baseline.
Okay. And continuous?
Continuous, the variation in fever will be less than 2 degree Fahrenheit, the variation in temperature.
Okay. All right. So this patient had low-grade fever, intermittent in
Yes, sir.
nature, evening rise associated with night sweats. All right.
Yes, sir.
But not with any chills and rigor.
No, sir.
All right.
Yes, sir.
And it was relieved on taking paracetamol. That's what you're trying to say.
Yes, sir.
Okay. Next slide.
Patient also complained of cough, which started 3 months ago. Cough is associated with production of sputum that is scanty, white in color, without blood. There is no postural or diurnal variation of cough. There is no history of close contact with any animal for a long duration. No history of
Hold on,
breathlessness. Yes, sir.
hold on for cough. Go back to the previous slide. Hmm. So what is the total amount in 24 hours of the sputum? When you say scanty
So,
means less than,
um,
what do you mean by scanty?
sir, I'm not sure about the amount.
And why is it white in color? White is not the correct word to use. It's a colorless
So
generally.
colorless. Okay,
Hmm.
colorless.
Scanty means you can hardly measure the sputum quantity.
Yes,
Okay.
sir. Yes,
Otherwise, you
sir.
will say 1 teaspoonful in a day, or two teaspoonful, or half a katori in a day. All right,
Yes, sir.
something like that.
Hmm. Yes, sir.
Okay. What is this cough? This cough is, you said no postural dilated variation of cough, but furthermore, is this cough having any relationship with ingestion of meals? Does it have any relationship
No,
with
sir.
uh, does he get bouts of cough after exertion? Even those points are
No,
important.
sir. Yes, sir.
So relationship with meals, relationship with activity.
Yes,
Activity means
sir.
physical activity.
Yes,
Not
sir.
only the postural or diurnal variation, but also these are important thing to know,
Yes, sir.
isn't it?
Yes, sir.
Does this cough become more prominent during episode of low-grade fever?
Hmm.
Even that you may ask.
Okay, sir.
Many people would understand cough as sputum as well in a local language. So
Hmm.
you have to be asking them direct leading question whether cough means you have some sputum or so-called bulgum or not,
Hmm.
or it is absolutely a dry cough.
Okay, sir.
What are the common causes of dry cough?
Sir, like dust inhalation, even
So one is
an
exposure
ACE
to air
inhibitor intake. Yes, sir.
exposure to air pollution. Okay, next.
Sir, ACE inhibitor intake,
Okay. What is the cough like in
malignancy.
bronchial asthma?
Sir, in bronchial asthma, there is sputum production.
Is that's very scanty.
Okay, sir.
All right. Any other condition you know when there is a dry cough?
COPD.
Again, COPD would have more sputum rather than bronchial asthma.
Okay, sir.
Yeah. What else?
Smoking.
Post-viral tracheobronchitis
Post-viral
is one of the
pneumonia.
most common.
Hmm.
Post-viral tracheobronchitis is one of the most common, and post-viral URI. Lot of people, and you must
Yes,
have
sir.
also experienced for 2-3 weeks continue to
Yes,
have
sir.
some dry cough.
And sir,
What
COVID.
else? COVID.
COVID-19.
No, many things more important.
Uh, Gastroesophageal reflux.
Yes, that may also produce. And also people who get acute episodes of during first phase of acute LVF.
Okay, sir.
All right, let's go to the next complaint.
So then there's negative history. No history of close contact with any animal for long duration. No
Why did
history
you
of
take this?
breathlessness.
Why did you take this history of
Sir,
animal contact?
sir, for hydrated cyst.
Hydrated cyst. Okay. All right.
No history of breathlessness or wheeze. No history of change of voice. No history of chest pain. No history of heart valve replacement. No history of acid reflux. No history of aspiration. No history of any drug intake except paracetamol. No history of backache, no history of headache or seizure, no history of any increase in frequency of micturition or blood in urine.
What about these last 3 points in history?
So basically, if there is a suspicion of tuberculosis, then to rule out if it has spread to the spine or if it has led to meningitis or renal TB.
Sorry?
Sir, to rule out if there is TB, then if it has spread to the spine or the meninges or renal TB.
Okay. 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 What about this micturition?
Sir, for renal TB or in a male,
Hmm.
even the prostate could get affected.
Does the renal TB produce increased frequency of micturition?
No, sir, but hematuria.
Hmm? Yeah, hematuria may be there.
Hmm.
Hmm. Go to the previous slide.
Sir,
Change of voice.
sir, in case there was a malignancy in the lung.
Mm-hmm. Okay. So malignancy producing this cough. Okay. For that matter, any parenchymal disease the lung can
Yes,
produce.
sir.
And one of
Yes,
the
sir.
most common other, which we really do not talk much, is interstitial lung disease.
Yes, sir.
So that may also produce cough, dry cough.
Hmm.
In fact, in idiopathic pulmonary fibrosis, one of the most common interstitial lung disease, dry cough is the most important symptom.
Yes, sir.
Chest pain,
Sir, in case for pleuritis and also in case of any heart disease, like if there was mitral
mm-hmm.
stenosis or anything.
Mitral stenosis, it does not really produce chest pain.
Yes, sir.
That
More
really
that
does.
would be more for palpitation and all.
Mm. But
Hmm.
yes,
Mainly.
patient with a left ventricular dysfunction because of ischemic heart disease, who can
Yes,
go
sir.
into acute pulmonary edema or left ventricular failure, or develop biventricular failure consequent to ischemic cardiomyopathy. They may have chest pain as well.
Yes,
Anyhow,
sir.
let's go to the next slide.
Family
Hmm.
history. Patient's father was diagnosed with pulmonary TB 2 years back. He completed treatment and recovered. No family history of malignancy.
So 2 years back he had.
Yes, sir.
So must have taken treatment for 6 to 9 months,
Yes,
and
sir.
and he develops disease after a gap of 12 to 15 months of completion of treatment of his father. So
Yes,
how do you
sir.
think?
He might have had contact when the father was infected and hadn't been treated, and it could have been lying dormant for a while.
So how long it can lie dormant?
Mm. So I'm not sure how long secondary TB can lie dormant. Primary can lie for years and decades.
Hmm. So for a TB acquired from other active case, lying dormant is as possible as with the primary. Why I'm saying
Okay, sir.
that is it depends on body's immune response. All right.
Hmm. Yes, sir.
But having said that, chances of a person acquiring it from other and developing after a gap of 1 year is little unusual.
Okay, sir. Okay,
All
sir.
right. We cannot
Hmm.
completely rule that out, but little unusual. All right.
Okay, sir.
So was his father having an active? Was he having a case pulmonary TB of active disease? I mean, a positive smear or negative? Does that history available? Is that history available?
It's not available, sir.
Okay, because that also would reflect if it is an active, if it is a smear positive TB, then chances of spread to others are more rather than if it is a
Yes,
smear
sir.
negative.
Yes,
Okay.
sir.
Although we know that if there is a pulmonary parenchymal disease, it being smear positive, chances are much, much more.
Yes, sir.
Okay. Let's go to the next slide.
Socioeconomic history. Belongs to upper lower socioeconomic class as per modified Kuppuswamy scale. He lives in a one-bedroom house with his parents and sister. Overcrowding is present and ventilation in the house is poor.
Okay.
Personal history. Patient has lost 5 kgs in the last 3 months. That is significant weight loss.
When
Patient
you
has
when you
reduced up.
when do you call it significant weight loss?
So loss of more than 5% body weight or more than 4.5 kg in 6 to 12 months.
5%? Where is this definition of 5% has come from?
Sir Harrison,
It has to it has to be 10%, is it? Is Harrison says 5%? Are
okay,
you
okay,
sure?
sir, 10%, 10%.
No, no, no. Don't yield so easily.
Okay,
Your
sir.
name, your Tejaswini. What's your name?
Yes, sir, Tejaswini.
Tejaswini is the name by name. It becomes that you have to fight for your case.
Okay, sir.
So is it 5% or 10%?
Sir, 5 to 10%.
Five. As far as I remember, it is 10%, but maybe if the new addition says 5%, I'll take it. So anyhow, the loss, 10% loss is considered as significant. So
Okay, sir.
you need to know what was his weight.
Yes, sir.
If it weighs was 50 and he's lost 5 kg, it automatically qualifies 10% loss,
Yes, sir.
isn't it? Okay.
Yes,
So
sir.
he has significant weight loss. Then,
Then he has reduced appetite. He does not smoke cigarettes or BD. No history of addiction to alcohol or any other substance abuse. Bowel and bladder habits are normal. No sleep pattern abnormality and mixed diet.
mm-hmm. All right.
Past history, there is no history of diabetes, hypertension, or thyroid illness. No history of receiving blood transfusion. No history of any surgery or prolonged hospital stay.
Why do we lay so much emphasis on history of blood transfusion?
Sir, it could have led to hepatitis or HIV. And if a patient with HIV has TB, he's more susceptible and it's more likely to be severe.
Mm-hmm. Okay. All right. Okay. Next.
Summary after history taking. A 30-year-old gentleman presented with fever with evening rise and night sweats for 3 months, accompanied by productive cough, significant weight loss, loss of appetite, and history of close contact with diagnosed case of pulmonary TB.
Mm-hmm. Why did you say productive cough when you're saying very scanty sputum?
Sir, because
Because it
sputum was
doesn't go
still
hand in hand.
there.
Yeah, it doesn't go hand in hand,
Okay, sir.
Accompanied by,
So then when
anyhow,
should we call it?
you,
Hmm.
I mean, you
When
can
should we
call
call
it.
it productive cough?
Yeah,
Okay.
you can call it accompanied by cough with mild expectoration. Okay, all right, you can use
Okay,
productive.
sir.
Mm-hmm.
General physical examination. Patient was
So,
examined after take. Yes, sir.
yeah, go ahead.
Okay. Patient was examined after taking due verbal consent in a well-lit room. Examination was carried out in sitting position. He was oriented to time, place, and person. Height 150 centimeter, weight 48 kg, BMI 21.3.
Yeah, go ahead.
Vitals, pulse was 77 beats per minute, regular in rhythm, normal character and volume, no radial or radiofemoral delay. All peripheral pulses are palpable. Blood pressure 118 by 74 mmHg measured in the right brachial artery and sitting position. Respiratory rate was 15 per minute and abdominothoracic. Temperature afebrile at the time of examination. JVP was not raised. Pallor, icterus, clubbing, and edema were absent. On oral examination, there were no caries, no pigmentation, no mucosal ulcers, or any growth in the oral cavity.
No,
Lymph node
so before that,
examination.
no, before you go to lymph node examination, so general physical examination does not reveal any finding, any positive finding,
No, sir. No, sir.
no abnormal. Okay,
Hmm.
all right. What do you expect in such a patient in general physical examination?
So the patient could appear emaciated because TB is associated with weight loss.
Okay, very good. Anything else?
If there is liver involvement, there could be icterus.
Okay, what else? Although it is very, very rare, TB in liver
Okay.
producing icterus is very, very rare. Why I am saying so? Are you able to hear me?
Yes, sir.
Why am I saying? Why am I saying so?
Sir,
The
because
most common, yeah, yeah. Go ahead.
generally the liver involvement will not be sufficient to impair the function to such an extent that
No, no.
jaundice occurs.
The,
Hmm.
yeah, you're right. But either TB involve liver as granulomatous hepatitis, which generally presents with fever and raised alkaline phosphatase,
Okay,
or
sir.
TB involves rarely as a tubercular abscess in the liver, which is very, very rare.
Yes, sir.
It does not
Yes, sir.
produce hepatitis. All right,
Hmm.
does not
Yes, sir.
produce hepatitis. Anyhow, so jaundice you said one, second you said emaciated, and
Hmm.
third the most common with chronic illness would be pallor.
Yes, sir.
All right. Okay,
Yes,
let's
sir.
go to the lymph node examination.
A single mass of 3 by 3 centimeter was felt in the anterior triangle of the neck on the right side. It was matted in consistency, non-tender, no redness, scar mark, or sinus on the overlying skin, not fixed to the overlying skin or the muscle below. No inguinal or axillary lymph nodes were enlarged on palpation. Systemic examination,
So go to the
abdominal examination.
previous one again. Matted, non-tender,
Yes, sir.
no redness, scar marks, sinus on overlying skin present, not fixed
Yes, sir.
overlying skin or the muscle below. All right. But it was a matted. When you say matted, is that consistency? Consistency is never matted. Consistency is
Okay,
soft,
sir.
firm, hard. Okay.
Okay, sir.
Hmm. So you would say a single mass, a single matted mass, you can say, or single mass of this and this on this side, which appears matted. Matted means multiple together.
Yes,
Is
sir.
that right?
Yes, sir.
Consistency you'll have to write soft to firm.
Okay,
Okay.
sir.
Rest all rest is all okay. Next.
Abdominal examination. Patient is examined in supine position, semi-flexed at knee and hip joint. On inspection, there is a scaphoid abdomen. All quadrants move equally with respiration. Umbilicus is central and inverted. No scar marks or dilated veins present on abdomen. No visible peristalsis. On superficial palpation, there is no tenderness, no local rise of temperature, and no fluid thrill. On deep palpation, enlarged liver is felt 2 finger breadths, that is 3 centimeter, below the right costal margin at right mid-clavicular line, non-tender,
What is
There's a
the
sharp.
normal liver? What is the normal liver span?
So we should not be able to feel it below the coastal margin.
No, but yeah, what is the normal span as such? You know how many
Um,
centimeters?
so I can't recall right
So
now.
minimum is 10 centimeter.
Yes, sir.
All right, liver span. That's minimum.
Yes. Okay,
It
sir.
may be 12 also. That can also be normal.
Hmm.
13 can
Yes,
also be
sir.
normal.
Hmm.
But anything beyond 14, 15 becomes generally abnormal. Anything
Enlarged.
beyond 15.
Yes,
Okay.
sir.
Go ahead. Non-tender. Next. Sharp
Uh, sh-
margin. No, previous one.
Sharp margin. Firm. So it should be firm in consistency. I don't know why. There's a typing error.
No, that's all right. Firm inconsistency. Okay.
Yes,
Yeah.
sir.
Go ahead.
And no pulsations of liver are felt.
Hmm? A smooth
No
surface.
pulsations.
You know.
Yes, sir. Yes, sir.
Previous
There should
one.
be smooth surface, not consistency. Yes, sir.
Hmm. No pulsations of
And no.
liver felt. What what is the significance of pulsations of liver?
So it could
What
represent a
condition you feel pulsation?
hemangioma.
Okay. Any other
Um,
condition when you feel pulsations are felt?
Sir, tricuspid regurgitation.
Very good. Very good. Severe congestive heart failure also you may sometimes feel.
Yes, sir. Hepatocellular carcinoma.
Oh, that would yeah, maybe because of increased vascularity, a little unusual. Okay. Go ahead.
Spleen. Enlarged spleen is felt 1 finger breadth, that is 1.5 centimeter, below the left costal margin in the left midclavicular line. It is non-tender, firm, smooth surface, and splenic notch is felt on the medial border. No other mass is palpable in the abdomen. All hernial orifices are intact and external genitalia is normal.
Mm-hmm.
On percussion, upper border of liver dullness starts from the fifth intercostal space along mid-clavicular line. Therefore, the liver span is 15 centimeter, and in spleen, dullness is felt in Probus space. Auscultation,
Mm-hmm.
Walid, previous slide.
Can you
Auscultation,
go back
normal
to the
vowel sounds.
slide previous? Go back to a slide previous. Okay. Next. No, that's okay. Next.
On
So it is very
auscultation,
important for all you who are listening. It is all very important for all you listening this. You have to look for a splenic notch to be very sure that you are only palpating spleen and not the kidney. Okay? And kidney is generally not palpable without a bimanual palpation. So this is an important thing you should remember always. Go ahead with the percussion.
upper
So
liver
here it
border,
comes. The liver span here is,
yes, sir.
yeah.
Upper border of liver dullness starts from the fifth intercostal space along mid-clavicular line. Therefore, the liver span is 15 centimeter. And for spleen, dullness is felt in Probus space. Auscultation, normal vowel sounds are heard and no bloat or venous hum.
Okay.
Respiratory system, inspection, palpation, and percussion were unremarkable. On auscultation, crepitations were heard in the infraclavicular and suprascapular area on chest on the left side that corresponds to left lung upper lobe, especially during inspiration and after coughing. Cardiovascular
Okay.
system, apex beat in left fifth intercostal space medial to the midclavicular line, normal heart sounds heard. Nervous system, There is no sign of increased intracranial tension or meningeal irritation, no focal neurological deficit. Motor and sensory system examination was normal, and all reflexes were normal bilaterally. Summary: a
So
30-year-old
just
gentleman.
the previous one. All right. There are some crepitations in the infraclavicular and supraclavicular area on the chest and left. Okay.
Yes, sir.
All right. Go to the next. No, no. Next. Yeah. Next. Yeah. Summarize.
A 30-year-old gentleman presented with fever with evening rise and night sweats for 3 months, accompanied by cough productive of scanty sputum, significant weight loss, loss of appetite, and history of close contact with a diagnosed case of pulmonary TB. On examination, cervical lymphadenopathy, mild hepatomegaly, and mild splenomegaly were present. Crepitations were heard in area of upper lobe of left lung. Examination of other systems revealed no abnormality.
Okay. So what are the possibilities?
So in infectious diseases, it could be disseminated TB, it could be Kala Azar, it could be malaria, it could be an autoimmune disease like systemic lupus erythematosus, could be Hodgkin's lymphoma, sarcoidosis, amyloidosis, metastasis.
So, Tejaswini, go back to the
Yes,
previous
sir.
slide. So you made a diagnosis of infectious diseases, disseminated TB, Kala Azar, malaria. Why did you make a
Yes, sir.
diagnosis of malaria?
So because there is hepatomegaly and splenomegaly, and
How do you see
there is
lymphadenopathy in
fever.
malaria?
Yes, sir.
When do you see lymphadenopathy in malaria?
Oh, yes, sir. Not lymphadenopathy.
Hmm.
Hmm.
Rest all one can consider, yeah, but not certainly malaria.
Yes, sir.
Okay. Hmm.
Yes, sir.
Next. Next.
Investigations ordered: complete blood count and peripheral smear, Montu test,
Hmm.
chest X-ray and
Hmm.
sputum examination for acid-fast bacilli, CB-NAT,
Hmm.
USG abdomen, liver function test, and lymph node biopsy.
Hmm. Okay. So ideal, these are good tests. CBNet for?
For tuberculosis, sir.
Okay. All right. Next. Anything else you have?
Yes, so there are more. Waleed, next slide,
Next
please.
slide.
So I think there might be a network issue. Maybe that's why it's not changing. I'll just contact him. Just a minute, sir, please.
No problem. मैं तुम्हें मेल भेजिए ये वाला फोटो है ना ये वाला फोटो तुम्हें रंगोली में जाके प्लेट करवाना ठीक है और उसका साइज पता करें
If the investigations do not yield a diagnosis of TB, then we can do a CT scan of the abdomen. We can do an image-guided biopsy of liver and bone marrow. We can look for anti-nuclear antibodies, serum ACE levels, and we have to look for what we see in the lymph node biopsy. If TB is confirmed, then it is compulsory to notify the case. We can do a CT abdomen. We have to look for the drug resistance pattern on CBNAT, and we have to do HIV testing after taking due consent. We also have to rule out that the other systems might be involved. So we have to do a lumbar puncture. We have to do a urine analysis, kidney function test, ECG, and serum electrolytes.
All right.
And this is the image of sudden staining of acid-fast bacilli and the miliary mottling that is seen on chest X-ray in miliary TB.
Just for a second, miliary TB never produces a localized crepitations. Okay.
Okay, sir.
Generally doesn't produce. Anyhow, go ahead.
Differential diagnosis of military pattern on chest X-ray. Infections like TB, fungal infections like coccidioidomycosis, plastomycosis, histoplasmosis, or chickenpox. It could be due to dust inhalation like beryllium or coal miners pneumoconiosis. It could be due to a hyaline membrane disease, metastasis, histiocytosis X, hemocirrhosis, sarcoidosis, amyloidosis. Diagnosis: my patient, 30-year-old male, is a case of disseminated Cox disease with involvement of the liver, spleen, and lymph nodes without evidence of pleural, brain, genitourinary, or gastrointestinal tract involvement. For treatment, treatment depends on the weight category of the patient, and it's divided into an intensive phase and a continuation phase. The intensive phase is for 2 months, in which we give isoniazid, rifampin, pyrazinamide, and ethambutol. In the continuation phase for 4 months, we'll be giving isoniazid, rifampin, and ethambutol. Walid, next slide, please. We will
You will
also give
do only
prophylactic.
this you will only do once you have confirmed your diagnosis.
Yes, sir, after confirmation of diagnosis.
So definitely you, if he has active sputum production, sputum AFB, and this can help you, isn't it?
Yes, sir. Yes, sir.
And secondly, lymph node biopsy. These two would be clinching your diagnosis in addition to
Yes,
chest
sir.
X-ray. Okay, so these are
Yes,
the
sir.
doses you said. Okay, so what is the most common side effect of these drugs?
Sir, isoniazid can lead to peripheral neuropathy, which is why we have to give prophylactic pyridoxine to the patient, 10 milligram per day.
Mm-hmm.
And rifampin can lead to yellow discoloration of bodily secretions, so tears, urine can all be yellow colored. So we have to counsel the patient about that.
Mm-hmm.
Ethambutol can lead to visual problems. Now, pyrazinamide can be hepatotoxic, and it can also lead to increase in serum uric acid.
Okay, okay, very good. And pyrazinamide
Sir, increase in serum uric acid.
and also hepatotoxic.
Yes, sir.
So whenever a person develops ATT-induced hepatitis,
Hmm.
it is diagnosed when the liver enzymes are how many times more than normal?
Sir, I don't remember that.
Enzymes rising by more than 5 times the upper limit are considered
Okay,
as
sir.
considered as
ATT-induced hepatitis.
or bilirubin rising to any level. Okay, and this is a very common problem in our population when we give these drugs not according to proper body weight. A lot of time these drugs are given more than the required dosage and it produces.
Okay, sir.
All right, good presentation. Anything else you have?
No, sir.
Why is it repeating? My voice is being repeated. Anyhow, so
No, it's clear,
so
sir.
this so one thing I wanted to tell to everyone that lot many times not find a pulmonary TB and we just find only a lymph node TB. Okay, this looks like more of a disseminated TB because hepatic involvement, liver, spleen, lungs, nodes, everywhere there is involvement. Okay, but many times only lymph node TB, and patient may have no involvement of the lung, may have nothing, which is what you call as extrapulmonary TB. All right. So
Yes,
this
sir.
is a good presentation from you, and I'm sure everyone must have learned a little bit from it. So we can go to
Thank
the
you, sir.
next also if someone has prepared any case. Next one.
Morning, sir. Hello. Good morning, sir.
Yeah, you can start.
Sir- Okay, sir. Please, next slide, please. Sir, I'm presenting the case of Mr. XYZ, who is a 53-year-old male, a resident of Daryaganj, New Delhi. He is educated up to 10th standard and farmer by occupation. He presented to the
Can
hospital
we
with the
just
distension of.
hold on for a minute. Just hold on.
Okay, sir.
Just wait for a minute. You can start now. Hello? 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 Please start. Tanvi?
So, sir, there's a network issue there.
Tanvi?
Hello. So she has a network issue in the hostel.
Okay, okay.
It would take some time.
Hello? Hello?
Yeah, Tanvi, start.
Okay, sir. So the patient presented to the hospital with distension of abdomen since 1 month and yellowish discoloration of skin and eyes since 1 week. Next slide.
The patient was apparently well 1 month back when he developed distension of abdomen, which was. Yeah, go ahead.
Sir, I'm not able to see the slide.
Oh, you're not able to see it.
Walid?
At my
No,
end.
sir, I'm seeing the chief complaint slide. Sir, I'm able to see it now.
Okay, go ahead.
So uh, the patient was apparently well 1 month back when the patient was apparently well month back when he developed distension of abdomen, which was insidious in onset, gradually progressive, painless, and diffuse. There are no aggravating or relieving factors. There is no history of pain in the abdomen, no history of swelling of lower limb, facial puffiness, oliguria, no history of difficulty in breathing, orthopnea, PND. The patient also gives a history of yellowish discoloration of skin and eyes since 1 week, which is acute in onset, gradually progressive, first noticed in the eyes by the patient attenders. The patient also had a history of yellow colored urine since 1 week. There is no history of generalized itching, clay colored stool. Patient complains of history of decreased appetite since 2 months. There is no history of unintentional weight loss, easy fatigability, no history of fever. There is no history of altered. There is no history of altered sleep pattern, daytime drowsiness, no history of hematemesis, blood in stool, and melena.
Just hold on. So basically, there were two complaints: yellowish discoloration of the skin, and the second complaint was, Tanvi, what was that?
Yes, sir.
Distension of abdomen, isn't it?
Sir,
Can you hear me?
generalized distension of abdomen. Yes, sir. Yes,
Yeah.
sir.
So, and
Yes, sir.
the total duration of illness is 2 months. How much is the total duration of
Sir,
illness?
patient complaint distension since 1 month and sir,
Since
1 month.
and
1 month, sir.
this yellowish
Yes,
yellowish
sir. This is
discoloration
since one
since
week.
1 week.
1 week.
Okay, and 1 month back. Okay, but you said he had decreased appetite since 2 months.
Yes, sir.
All right. So all these things which you have taken as negative history, no history of fever, no history of altered sleep wake pattern, daytime drowsiness. Tell me the significance of all of these. And no history of generalized itching, clay colored
Yes.
stool. What is the significance of all these
Uh,
complaints?
sir, sir, generalized itching and clay color stools indicates that there is no obstruction. This is to rule out the obstructive jaundice. And
Okay.
And sir, history of unintentional weight loss or fatigability is to rule out weight loss is to rule out sir TB or like any malignancy. And sir, fever is to rule out
Rule out what? Rule out what?
डॉक्टर ललित मैंने आपके पास भेजा है पेशेंट है
Fever is to rule out what? Fever is to rule out what?
सर उनको ना आर्थराइटिस
Yeah, Tanvi. Fever for what? I think we again lost her. Yeah, Tanvi.
Hello, sir. There is a net issue at hand.
Yeah. What happened? आप अभी चले जाइए ओपीडी में डॉक्टर रश्मि से मिल लीजिए डॉक्टर रश्मि से मिल लीजिए मेडिकल ओपीडी
इससे ये पेपर दिखा दें
हाँ जी
बाद में कर लेना थोड़ा
yeah
Hello.
yeah go ahead
Hello,
who is
sir.
it
History of fever is to rule out any. Hello, can
rule
you
out
hear me, sir?
yeah
Hello,
yeah I can hear you
sir. History of fever is to. Okay, sir. Sir, history of fever is to rule out any infection or inflammation or like sir, yeah, and like lymphoma, sir. And sir, history of altered sleep wake pattern, daytime drowsiness is to rule out hepatic encephalopathy if there is. And the history of hematemesis, blood in stool, melena is to rule out sir like any bleeding, variceal bleeding, like
due to
sir due to maybe there maybe portal hypertension,
okay
there may be
all right
variceal bleeding, esophageal
mm.
variceal bleeding.
Okay, why can't all this be just simple viral hepatitis? All this can be seen in even acute viral hepatitis also, isn't it? Hello, I think she has a
Yes,
lot
sir.
of net issue. Can you hear me?
Yes, sir, I can hear you.
No, so what can't it be viral hepatitis? Okay, let's go to the next slide. Yeah, continue.
Hello?
Yeah, what is the problem with your net?
Hello?
Yeah, hello.
So there is a network issue in hostel.
In the hostel.
Yes, sir.
Hello.
Hello? Yes, sir.
Continue, continue.
Sir, past history. There is a history of similar complaint of abdominal distension, vomiting, and yellowish discoloration of skin and eye 8 months back, for which he was admitted to the hospital ward and treated with the medications, that is ursodeoxycholic acid 300 mg, Silver 70 mg, neurobiome. He was relieved and discharged after 1 week.
Carry on. Carry on, please.
Yes, sir. Next slide. So there is no history of hypertension, diabetes, mellitus, asthma, TB, and epilepsy. There is no history of any chronic drug intake, blood transfusion, tattooing, IV drug abuse, no history of intake of any herbal medicine. There is no history of surgery in the past.
Next.
Next slide.
You are not able to see?
No, sir, I'm not able to see.
What are you using? A laptop or a mobile?
Welcome to the webinar. You can enter as an attendee in listen-only mode.
What are you using? A laptop or a mobile?
Sir, I'm using tablet.
You're using a tab.
Yes, sir.
So you are not able to log in. You are not seeing the screen.
Sir, I'm seeing the screen of past history.
I think there is major issue with your network. If you have other devices on the network, just put them off.
So now,
Personal history.
sir, Now I'm able to see the personal history. The patient was a personal history. The patient consumes mixed diet. His appetite is reduced. Sleep is undisturbed. Bowel and bladder movements are regular and normal. Their history of he belongs to the socioeconomic history. He belongs to the lower middle class according to the modified Kuppuswamy scale.
Previous slide, please.
General
Previous.
physical.
Why you're not seeing now?
Hello? Hello?
Can you see the screen?
Nilayan bol rahe ho.
Good morning, sir. Sir, I'll try to present the rest of the case. I think they are
No, sir.
facing some internet issues.
Yeah, it is better that someone else presents. Yeah.
Yes, sir. So, in the personal history, sir, the patient reports a mixed diet with a reduced appetite. The sleep was undisturbed and normal bowel and bladder habits were reported. History of alcohol consumption for 15 years. Patient reports having brandy that is approximately 100 grams of alcohol per day, with the last drink consumed approximately 1 week before. There's also a history of smoking for 5 years, approximately 10 cigarettes per day. So it comes out as a 2.5 pack year history, and no history of any high risk sexual behavior. Coming to socioeconomic history, the patient belongs to lower middle class according to modified Kuppuswamy scale.
Hold on for a minute. So
yes,
this
sir.
history of alcohol, just hold on. This history of alcohol consumption is very significant, isn't it? We know
Yes, sir.
that anyone drinking more than 80 gram a day for 10 years is likely to develop
Cirrhosis, I think.
cirrhosis of the liver.
Yes, sir.
Okay, so this is very important. So what has happened to him right now? With distension of abdomen and just 1 week history of yellowish discoloration. So what has happened to him is basically he has developed already signs are there on history of a complication of alcohol consumption leading to cirrhosis, and on top of that he has evidence
acute
of
decompensation of cirrhosis,
acute
sir.
decompensation. There is jaundice, obviously. Okay.
Yes, sir.
So had there been a history in which there is just distension of abdomen and icterus developing, or there was an icterus developing with minimal distension of the abdomen, like what this patient has, distension of abdomen. Can you, on the basis of history, discern whether the patient has already got a cirrhosis of liver, or he is still in a case as acute hepatitis because of alcohol? How would you distinguish the two in history? Any clue?
So on the basis of history, sir, I'm not sure. I'm not sure, sir.
On basis of whatever is available till now, can one say that this patient has already developed cirrhosis, or it is still an acute alcoholic hepatitis?
So cirrhosis should have like some typical findings on physical examination, sir, but on the basis of history.
No, only on history. Yet. We are not going to the final examination.
So cirrhosis, I thought so maybe bile secretion would be somewhat hampered. So maybe a history
No.
of okay.
So what happens is that acute alcoholic liver disease, acute hepatitis alcoholic, would generally not produce significant distension of abdomen. Having said that, mild distension of abdomen may occur and there may be mild ascites. But if it is a significant one, then it is unlikely that it is only acute alcoholic hepatitis. So things are relative, but yes, one can only confirm it by clinical examination subsequently, or by why I raised this question was that there was a lot of negative history, nothing to suggest any esophageal varices, no encephalopathy, which are much more signs of a cirrhosis, portal hypertension. Okay, so those signs were not there on history. Those points were not there in the history. Only odd point was a significant distension. So initial stage cirrhosis, you may not have all those, and you may only have distension abdomen due to ascites, moderate to severe. All right. Otherwise, it can still be a acute hepatitis rather than a cirrhosis. Got my point?
Yes, sir.
Go ahead now, general physical examination. So
So
why
coming to
this case
general
has been
physical exam.
chosen? Why this case has been chosen here? Anyhow, go ahead.
So coming to general physical examination, sir, the patient was examined uh, in supine position. The patient was comfortably lying on the bed and moderately built, poorly nourished. The patient is conscious, cooperative, and well oriented to time, place, and person. Coming to vitals, the pulse was 76 beats per minute, normal in rhythm and character and volume, with no vessel wall thickening and no radial or radiofemoral delay. Respiratory rate was 16 per minute, and blood pressure was 120 by 80 millimeters of mercury measured in right arm in supine position. Temperature was 98.6 degree Fahrenheit measured in the axilla. Uh, there was no pallor, but icterus was present. No pallor, no cyanosis, no clubbing, no lymphadenopathy, and no edema. On head-to-toe examination, uh, the hair on the head, the scalp hair was sparse. Uh, in the eye, icterus was present, but no pallor could be visualized. Yellowish pigmentation of skin could be seen. Resting coarse tremor of the hands was present. Parotid swelling, okay, a negative, no negative, okay, parotid swelling, spider nevi, palmar erythema, white nails, flapping tremors, loss of axillary or pubic hair, debutant's contracture, gynecomastia, and testicular atrophy could not be seen. No angular stomatitis or ileitis, no petechiae or any purpura. Coming to abdominal examination, the patient was exposed from nipple to mid-thigh. And
Before you go to abdominal examination, so what are the abnormal findings? Just repeat that. What are the
so positive
positive
abdominal
findings?
findings. Yes, sir. So the hair on the head was sparse, and there was icterus. Icterus was present, sir, both in the eye and the skin, and there was a coarse resting tremor. So only
Okay.
these three findings.
Uh-huh. Okay. Okay. So an icterus was there. Sorry, repeat for me. I'm sorry. Icterus.
Yes, sir. Yes, sir. So, sir, head hair was sparse. There was icterus both in eye and the skin,
Hmm.
and a flapping, a resting coarse tremor was present.
Okay. All right. Okay. Vitals are all right.
Yes, sir.
Okay. Go ahead. Abdominal examination.
So, sir, coming to abdominal examination, the patient was exposed from nipple to mid-thigh and examined in supine position. On inspection, there was a generalized distension of abdomen that was noted. The umbilicus was central in position and inverted. All quadrants moving equally with respiration. No dilated veins, no scar sinus could be visualized. Hernial orifices were intact and external genitalia appeared normal. So some photo to demonstrate the
Okay.
points. Coming to palpation, on superficial palpation, no localized rise of temperature or tenderness could be elicited. On deep palpation, no guarding, no rigidity. The liver was enlarged with a size of 6 centimeter below the costal margin, firm in consistency, smooth surface, should have been nodular here, and sharp borders. Spleen is palpable 2 centimeters below the costal margin by dipping method, and it was non-tender. Kidneys were non-palpable. Uh, on percussion, liver dullness was felt in the upper border of which was in the fifth right intercostal space on full expiration. The lower border extended till 6 centimeter below the right costal margin in the mid-clavicular line on full expiration. The liver span was subsequently measured to be 7 centimeters for the right lobe and 9 centimeters for the left lobe, and shifting dullness was present.
Okay.
On auscultation, normal bowel sounds were heard, no venous hum or arterial bruit, no bruit heard over liver or spleen.
Okay.
Uh, so coming to systemic examination, in the cardiovascular system, normal S1 and S2 heard, no murmurs or additional sounds were heard. In respiratory examination, normal bilateral vesicular breath sounds heard with no extra added sounds.
Okay.
So coming to CNS examination, sir, no abnormality detected, and higher mental functions were normal. And sir, to summarize the case, uh, 53-year-old gentleman belonging to lower middle class presented with abdominal distension for 1 month and yellowish discoloration of skin and eyes for 1 week, with history of similar episode 8 months back. 8 months back. On examination, there is hepatomegaly and mild splenomegaly. Other systems were normal.
So what is the significance of all right differential? Yeah, give the differential diagnosis.
So first differential would be cirrhosis of the liver with possible portal hypertension. Second would be hepatic vein thrombosis, that is Budd-Chiari syndrome. Third would be hepatocellular carcinoma, but this is third, sir, lower down the list. And fourth would be acute alcoholic liver disease.
Why are you thinking of all these four? Go back to the previous slide. Yeah.
Sir, so I think cirrhosis of the liver, as you mentioned, that the abdomen was distended, sir. So that may point us to a chronic etiology. So cirrhosis of the liver should be there. And sir, also the alcoholic history, sir. I think more than 80 grams per day for 10 years is quite significant and can cause cirrhosis. So, putting that here. So hepatic vein thrombosis. So this is an acute decompensation, sir. So hepatic vein thrombosis can be possible, especially because we have splenomegaly, sir. And to explain
So
splenomegaly, we have to have a portal hypertension. So, but Cherry syndrome may explain that.
what happened 8 months back? What was that history 8 months back?
Sir, patient is alcoholic, sir. So it is possible that patient had an attack of acute hepatitis back then, and this is a recurrent episode.
Okay. All right. Okay. And why are you
And the
thinking of
hepatocellular.
hepatocellular carcinoma?
So this is sort of like just a distant a differential, sir, so that we don't miss out, because it is possible, sir, because eventually cirrhosis can progress to hepatocellular carcinoma, sir. We can never be so sure. And sir, on findings, there is nothing as such suggestive of hepatocellular carcinoma, but just that in the natural course of history, sir, HCC is a possibility, sir. So just mentioning it here.
But that's not so common, no?
Uh,
All right. So
yes,
we
sir.
should always keep common things. Okay. I would not keep
Yes,
it here. Anyhow, alcoholic liver disease, okay. All right, go ahead.
So investigations ordered, sir. Routine blood investigations would be hemoglobin, TLC, DLC, and ESR. So TLC, DLC may be to check for any foci of infection. Urine examination, plasma proteins, very important, sir. Ascitic tap. In ascitic tap, we have to determine the cell counts as neutrophil ANC of more than 250 cells per millimeter cube indicates SBP, spontaneous bacterial peritonitis. Gram stain and culture of the ascitic tap is very important to look for bacteria. However, this is often negative, and a negative culture does not rule out SBP. And serum albumin to ascites gradient to help ascertain if ascites is caused by portal hypertension or other causes. Cytology to see
Okay,
malignant cells, and amylase to rule out pancreatitis.
okay.
So continuing investigation, sir, some imaging such as USG. It is very sensitive to detect even small quantities of ascitic fluid, and it may also show compression of IVC. So something like sir, HCC compressing the IVC and causing the features, maybe. Liver function test, very important in this case, and liver biopsy to rule out any malignancy, and routine investigations like chest X-ray, ECG, echocardiography, just to rule out other possible differentials.
Okay.
Uh, okay, so so this is basically
So this is
grading
the
of
treatment part
ascites.
you are talking.
Yes, sir. Treatment on the basis of ascites,
Mm-hmm.
sir. Like how do we
Okay, but
treat the ascites?
go back to the previous slide. Go back to the previous. Hmm.
Yes, sir.
You don't do nowadays any biopsy for cirrhosis generally. All right. Now it has become an obsolete thing to do a biopsy for cirrhosis because you have such good imaging techniques. All right. Yes, you would
Yes,
certainly do for suspected malignancy. Yes, you would do that. All right.
sir. I think for cirrhosis we do something like fibrous cancer. I heard it in OPD. I'm not sure what it is, but
Fibroscan, fibroscan is also, yeah, okay, but you don't really need it. You can only for academic purposes, if you want to do, you do. Otherwise, for diagnostic purposes, now you don't do that. All right, these are all things you would do. Okay. So we have brought about an issue of pericardial effusion, constrictive pericarditis here.
yes, sir.
So that is a possibility. Is that a
Sir,
possibility?
pericardial etiology is mostly present with features of right heart failure. So hepatomegaly is possible, ascites is possible. However, splenomegaly is not usually seen in acute decompensation. And sir, jaundice may be present, sir. It can present this way, but there is, I think we checked for JVP in the vitals, and the JVP was not raised. So I don't think we should put it as a differential here.
Hmm. Okay. All right. All
So, sir, coming to treatment for ascites, sir.
Yeah, go ahead.
So grade 1 ascites that is only detected by ultrasound, sir, does not usually require any treatment at all. A grade 2 or a moderate ascites will respond, may or may not respond to moderate salt restrictions. Uh, if uh, if in a case it does not respond to salt restrictions, we can always add a diuretic. And diuretic of choice in case of liver etiologies is aldosterone antagonists. But if it is resistant to aldosterone antagonists, so we can add on a loop diuretic as well. A grade 3 or a 10 ascites is basically we follow the treatment protocol for grade 2 ascites, but we also do paracentesis. So paracentesis is both diagnostic and therapeutic, sir. Diagnostic in the sense of let's say it allows us to do cytologies and SAG, but therapeutic as well in grade 3 ascites. And so the aim of the diuretic therapy that we initiated for ascites, uh, the aim would be if a patient has only ascites, then the weight loss of 0.7 kgs per day is targeted. However, if the patient has both ascites and edema, then 1 kg per day of weight loss is targeted. And so then there's a table of
Okay.
diuretic dosage. So, sir, bed rest management would include number one would be bed rest, as it induces diuresis by increasing renal blood flow. Dietary restriction of sodium, as we know, so we want to decrease the body retention, fluid retention, and a fluid restriction to 1 to 1.5 liters per day if sodium is under 128 millimoles per liter. Diuretics, we use oral spironolactone with or without a low diuretic. Beta blockers can be added to prophylactically decrease any chances of esophageal bleed. Uh, it decreases basically the portal pressure, so the chances of bleed reduces. And thrombolytic therapy in case we are suspecting Budd-Chiari syndrome. So
Good.
that is all.
Good presentation. Though you did a proxy for your friend.
Yes, sir.
Anyhow. So, but anyhow, I was just uh, trying to say that probably this was not an ideal case for our presentation because there is no lymphadenopathy here, isn't it?
Yes, sir.
So you should have, I mean, ideally you should have not chosen it. But anyhow, good. When I said Budd-Chiari, one of the option I gave to you about Budd-Chiari was Budd-Chiari, which is sometimes the causes for Budd-Chiari are infective, and infective causes may have lymphadenopathy. Okay, so that was my aim rather than alcohol-induced cirrhosis and portal hypertension. Okay,
Okay,
no
sir.
issues
Got it,
with
sir.
that. Are we having one more case or no more?
Yes, sir. We have one more case coming up, sir.
Yeah, so we can go to
Yes, sir.
that, and anyone, all of you should write in chat box any of your queries. I can see that. All right, keep writing so I can reply to them. All right, so let's go to the next case then. And I hope there is no network issue with the next person who is presenting. Hmm?
Hello, sir. Am I audible?
Yes, 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 Walid.
Sir, my
You
name
are
is Walid.
Walid.
And
How do we pronounce you? Walid?
sir, it's Walid.
Walid. Okay.
Walid.
D is silent.
No, sir, nothing is silent.
D is
It's
silent.
Walid. Walid. The Walid.
Walid the or Wali?
Walid.
And D is silent.
No, sir.
Anyhow, go
No,
ahead.
sir. D is not silent. So I'm presenting a
Speak.
case of fever with splenomegaly and lymphadenopathy. So my patient's name is Mrs. XYZ. Her age is 30-year-old female. She is IT professional by occupation and resident of Delhi. She presented to OPD 5 days back with chief complaints of swelling in the neck for 6 months and fever for 4 months. History of presenting illness. The patient was apparently well 6 months ago when she noticed the swelling in right side of the neck, which was insidious in onset. It was single pea-sized swelling initially, which progressed to multiple grape-sized swelling on the same side 3 months back. There was no pain or no draining pus. The patient developed fever 4 months back, which was insidious in onset, low grade, not measured by the patient. It was occasional, lasting for few days, and associated with night sweats, not associated with chills and rigor and rash. There is no history of cough or shortness of breath, sore throat, weight loss, fatigue, chronic medication intake, itching, skin rash, frothy urine, cola colored urine, facial puffiness or swelling of legs, and fall. We basically asked the history to rule out other diseases such as TB, infectious mononucleosis, and other cancers such as ALL and secondary mets. And complications also, such as basically the lymphoma can present with unusual symptoms such as SVC obstruction, anemia, pleural effusion, ascites, nephrotic syndrome, erythema obstructive jaundice, and cerebellar degeneration. Hello?
Before you
Should I
go
continue?
further, Wali, let me ask you some questions. So here is a patient who is, how old is the patient?
It's a 30-year-old female.
And presenting complaints may are?
So swelling in the right side of the neck for 6 months and fever since 4 months.
Fever since 4 months. Okay. Uh, and she's 30-year-old. Okay.
Yes, sir.
All right. And then you've given us whole list of negative things and other things also. Okay.
Yes, sir.
But you have not talked about any constitutional symptoms. Does she have any constitutional symptoms?
So she has evening rise of, she has sweating in the night. I have written here.
But only
The fever was associated with night sweats, but it was not associated with any weight loss.
nothing. So no other constitutional symptoms, no fatigue, no malaise.
So generally we see these
And
symptoms
you
in a
have
patient.
and the fever. What is the nature of the fever you have not described? Just low grade,
Yes, sir.
occasional, lasting for a few days, isn't it?
Yes.
So
I
that's
should have.
very unusual.
Yes, I should have mentioned about the complete
What is the
history.
fever pattern in lymphoma? What is the fever pattern in lymphoma? Whether you
So
talk about, yeah.
So it is palapstin type of fever. It basically persists for few days, and then there is a period of remittance, and then it occurs. It is a remittent type of fever.
But this fever is generally not low grade. It is moderate grade fever.
Okay, sir.
So it is generally not low grade.
Okay, sir.
Since we know that you are presenting, you know already, and I also know that you are presenting a case of suspected lymphoma. So we know already. That's why we are thinking that there is this possibility. Okay.
Okay, sir.
All right.
Should I continue further?
So, but it's not absolute. All these features may also be there. All right. Let me make it very clear.
Okay, sir.
And it all depends on individual's immune response. How do you respond to it? All right. So, but by and large, let's talk about what is more common. And the very fact that there will be no chills in rigors also may not be true. They may have some episodes of fever with chills also. All right. Although very, very uncommon.
Okay, sir.
Next, please. Next. Go to the past history now. What else you wanted to know in his present history? There's so many negative points you told me. What other things do you want to know?
So any associated symptoms of lymphoma, such as swelling in any other part of the body, and
Okay.
history of any weight loss, such as we asked about the loosening of clothes,
Okay.
which is which is very common in lymphoma.
Okay.
And the family history also.
Why family history is important?
So there can be a genetic basis of lymphoma also.
Mm-hmm.
And so any infection such as EBV, extreme virus history, such as we basically ask
Mm.
about the sore throat.
Yeah, very important. Very important. Very good point. Yeah. Okay. So let's go ahead with the past history.
So she is not a known case of hypertension, diabetes, or HIV, hepatitis, or seizure disorder. No past history of Coats disease. Family history. No history of Coats disease in any of the family members, and no history of any cancer.
Mm. What you should always ask in past history is any history of hospitalization. That should
Okay,
also
sir.
always be asked in any past history. Okay.
Okay, sir.
Personal history.
Um, she intakes a mixed diet. She has a normal appetite, normal bladder bowel habits, movements. No history of IV drug abuse or high risk behavior, such as engaging in multiple sexual partners, or no history of alcohol or smoking. She is married and has one daughter. Menstrual history. She
Okay.
has a normal cycle of 28 days of regular and 5 days duration.
Okay.
Summary. My patient, Mrs. XYZ, 30-year-old female, presents with history of
Mm-hmm.
progressive non-tender swelling on right side of the neck since last 6 months, and fever with night sweats since last 4 months,
Mm-hmm.
with no risk factor for TB, HIV, or EBV infection.
Mm-hmm.
Examination.
All right.
The patient is conscious, cooperative, and well oriented to time, place, and person, and was examined in a well-lit room with proper consent taken. She is of average build. Pulse rate was 78 beats per minute. Regular rhythm, good volume, with no radial or radiofemoral delay. The respiratory rate was 14 per minute, and the temperature was 101 degree Fahrenheit. The blood pressure was 124 by 78 millimeters of mercury in right arm in sitting position. General physical examination. On head-to-toe examination, there was no louse, no dandruff on scalp, no pallor, no icterus, no cyanosis, good oral hygiene, no engorgement of facial veins, no thyroid swellings, no edema around eyes and in lower limbs, no skin lesions, bruises or petechiae, and the gait was normal. Examination of lymph nodes. Lymph node enlargement was seen on the right side of the neck. There was involvement of supraclavicular, level 5B, and lower jugular. Level 4, lymph nodes that are 2.5 centimeter in size. They are discrete, rubbery, non-tender, freely mobile, without any sinus formation, no skin changes or raised temperature, and not fixed to the overlying skin. There was no axillary, epitrochlear, inguinal, popliteal lymph node involvement. Systemic examination. Patient is examined in supine position, semi-flexed at hip and knee joint. On inspection, the abdomen is flat, flanks appear empty, all quadrants moving equally with respiration. There are no distended veins or scar marks. Umbilicus is central and inverted. On palpation, there was no fluid fill, and on deep palpation, no hepatomegaly. Splenomegaly is felt 3 centimeter below costal margin, firm, non-tender with irregular surface, and there was no other abdominal mass.
So why irregular surface?
Uh,
You think there are lymphomatous deposits, which is very, very unusual in lymphoma. All right.
okay, sir.
Mm-hmm.
So the surface is
Go ahead. Anyhow, go ahead.
on percussion. Abdomen is tympanic, spleen. On percussing the spleen, there was dullness felt in the trapeze area. The shifting dullness was absent. On auscultation, the bowel sounds were normal.
Okay.
Respiratory system. Both sides moves equally. It was resonant on percussion. Bilateral, the airways were clear bilaterally. TBS. First and second heart sound were heard, and there was no other significant finding. CNS is within normal limits. No breast lump is palpable. Summary. My patient, Mrs. XYZ, 30-year-old female, presenting with history of progressive rubbery non-tender lymphadenopathy on right side of the neck since last 6 months with mild splenomegaly, no hepatomegaly, no other lymph node group involved, and having fever with night sweats since 4 months. With no history of cough, breathlessness, or heart, is most likely a case of lymphoma. My provisional diagnosis is that of lymphoma.
So this rubbery consistency, go back. Rubbery consistency. It is very typical.
Sir. Yes, sir. Rubbery and firm.
Okay. All right, go ahead.
Other differentials could be Coats disease, ALL, HIV, or infectious mononucleosis.
Okay. All right.
Initial investigations. Complete blood count
Only
was done
thing against infection. Only thing which is not favoring infectious mononucleosis is progressive increase in lymph node size. It doesn't occur. After a period of time, they become of size, fixed size, and they don't progress further. Okay, and there is some waxing waning thing going on in infectious mononucleosis. Off and on, you will have fever, coming, going. All right.
Okay.
So it is not a progressive disease. It is a self-limiting disease, and generally 3 months to 6 months. By that time, it then remits. Okay.
Okay, sir.
So those are some important points to remember. Next.
Okay. Initial investigations which were done were complete blood count with peripheral smear, hemoglobin, pulmonal test, chest X-ray, excisional lymph node biopsy, HIV ELISA. The results of initial investigations. Complete blood count and peripheral smear were within normal limits. Hemoglobin was 13 grams per deciliter. Pulmonal test was negative, and HIV ELISA was also negative. The excisional lymph node biopsy showed Reed-Sternberg cell of lacuna variant. The lacuna variant is characteristic finding of the nodular sclerosis type of Hodgkin's lymphoma. And on immunohistochemistry, there was CD15 and CD30 positive, TAX5 positive. So it is a case of classical Hodgkin's lymphoma. The Reed-Sternberg cell basically arises from the germinal center B cell. It is 5 times of lymphocyte, and it can also be seen in infectious mononucleosis or Burkitt's lymphoma. X-ray basically showed anterior mediastinal mass with no involvement of the lungs.
This one is the mass. Go to the previous one. This is the mass.
So
this is normally not seen. Okay.
Yes.
This much widening. Next.
Investigations which were done before treatment initiation and for prognosis. CT of chest, abdomen, and pelvis, PET CT, ESR, LDH, LFT, and KFT. Results. CT chest showed mediastinal lymph node occupying the anterior mediastinal, showing homogeneous attenuation with hilar lymph node enlargement. CT abdomen showed splenomegaly with celiac lymph node enlargement, and CT pelvis was normal. On PET CT, the spread of lymphoma was seen in cervical lymph nodes, mediastinal lymph nodes, and celiac group of lymph nodes. There was splenic involvement and not involving any other group of lymph nodes. The liver, bone marrow, or any other extra lymphatic site were normal. ESR was within normal limits, LDH was normal, and LFT, KFT were normal. This CT abdomen shows splenomegaly.
This is not spleen, this is liver. This is the spleen. Okay. This is the spleen which is enlarged, and this is the liver. Okay.
Okay, sir. Sorry, sir.
Yeah, and this is
And
stomach
on
and
PET.
gas. The stomach and gas, okay?
Yes, sir.
And this is the major thoracic aorta. Sorry, abdominal aorta. These are the major structures seen here for all of you. Okay, and these are intrahepatic vascular channels. Okay,
Okay, sir.
and this might be partly a shadow of the gallbladder, partly. Okay, go ahead.
Which one, sir?
PET
So where is
CT.
the gallbladder?
So these were those prominent lymph nodes here, and after 2 cycles, these lymph nodes here have reduced.
Yes.
Even here also.
There was
Yeah,
increased uptake
this
of
mass is
FDG in
reduced,
these areas.
and these areas, isn't it? So after therapy,
Yes.
these have reduced. Okay, for
Yes,
all
sir.
of you to see. Okay, go ahead.
So we do an Arbor staging for the Hodgkin's lymphoma. Stage 1 basically involves a single group of lymph nodes or one extra lymphatic site. Stage 2 involves 2 or more than 2 lymph nodes or extra lymphatic site on one side of the diaphragm. And stage 3 involves
Okay.
2 more than 2 lymph nodes on both sides of the diaphragm. And stage 4 is disseminated to various organs.
Oh,
Since the patient presented with mediastinal and cervical and celiac group of lymph nodes, I would like to classify it as stage 3-1. And she also presented with fever. So it is stage 3-1B.
good.
Final diagnosis and staging of disease. My patient is having nodular sclerosing type of Hodgkin's lymphoma, stage 3-1B, with involvement of right side cervical lymph nodes, mediastinal, celiac group of lymph nodes, and spleen.
Right.
The treatment options. Basically, we give radiotherapy for early stage disease, such as stage 1 and 2, or if there is any localized lesion. And for chemo, and the indications for chemotherapy are B symptoms and in advanced stages such as stage 3 and 4. The chemotherapy regimens which are available are ABVD. Doxorubicin is the generic name of adriamycin, bleomycin, vinblastine, and dacarbazine. Uh, the ABVD is the regimen of choice in most of the places. And there is also another regimen such as DCOP, which is becoming popular in the European countries nowadays and is used for advanced cases mainly.
Okay.
The radiotherapy which is given is about 3600 to 4400 centigrades, and
Not centigrade, rats.
okay, sir. Treatment of patient and follow-up. The patient was started on ABVD regimen of chemotherapy. 6 to 8 cycles were conducted. One cycle spans about 1 month because it was started because the patient has advanced stage disease, that is 3-1B. And after 2 cycles, PET scan was conducted to see any remission or effect of treatment and to guide further treatment. We also advise the patient about the risk of ABVD regimen because it can lead to infertility and secondary myelodysplasias, AML. And my patient has not completed a family, so she is warned about these possible side effects. And ABVD poses risk of cardiac and pulmonary toxicity due to doxorubicin and bleomycin respectively. And the patient should be monitored for any signs of toxicity. Hodgkin's lymphoma can be, the prognosis of Hodgkin's lymphoma can be done by IPS, that is International Prognostic Score. The poor prognostic factors are male whose age is 45 years old, advanced stage such as stage 4, serum albumin less than 4 gram%, hemoglobin less than 10.5 gram%, increased WBC more than 15,000 micro per microliter, and lymphocyte count less than 600 per microliter. That's it, sir. Thank you.
Okay, very good. Very good.
Thank you, sir.
So, any questions, please write in the chat box, and then I'll make small presentation to sum up some of the things. So I'm sharing my screen now. All right. You're not seeing my screen right now, isn't it?
No, sir.
Okay. Can you now see my screen?
Yes, sir. It's visible now.
Now it's visible. Okay. So now you can see?
Yes, sir.
All right. So very good presentations. I must thank you for nice presentations of these cases, although the second case was not appropriate. So I'll just sum up that what is hepatomegaly, and remember that palpable liver does not always represent hepatomegaly. That is very important. Sometimes it may be a displacement, okay? Or sometimes rarely a spinal deformity or an abdominal tumor, all right, or displacement of liver by lung pathologies. So this is what the normal liver span is. So generally anything exceeding 10 centimeter is considered as hepatic enlargement. And this is the placement you all know, functions you all know, and levels of grades. When more than 7 centimeter, it is considered as massive hepatomegaly. And what are the main 5 mechanisms? Infections, excessive storage, infiltration, congestion, and obstruction for hepatomegaly. And you talk about consistency, edge, surface, firmness. All right. We talk about edge and margin. You also talk about tenderness, very important. If someone asks me what are the 3 important causes of tenderness, one is infection, abscess. Second is congestive hepatomegaly. Third may be a malignancy. All right. Even but carry sometimes. Then pulsations, most important, as was told, tricuspid regurgitation. All right. So if there is pallor and liver enlargement, these all conditions you would consider. Infection, hemolytic anemia, nutritional, leukemia and lymphoma. All right. Jaundice, anorexia, hematemesis, then mainly cirrhosis, portal hypertension. Recurrent jaundice, then liver disease and hemolytic anemia. If there is problem in feeding or dyspnea, cardiac causes. If there are these skin findings and lymphadenopathy, leukemia. If cholinekia or platinikia, iron deficiency. If there is associated mental retardation, then these mucopolysaccharidosis and certain hereditary disorders. All these you know. So be sure that it is hepatomegaly and not a push-down liver. Always try to assess the liver span, consistency and surface. For spleen, as marked here, all right. Again, It is considered as enlarged if it is at least 1 centimeter below the costal margin in a child more than 6 months of age, but in 30% of newborns and 15% or less than 6 months, palpable is a normal variant. It lies within the left upper quadrant of the peritoneal cavity, abutting rib 9 to 11, the stomach, the left kidney, the splenic flexure of the colon, and the tail of the pancreas. This is how it is. All right. Normal spleen is less than 250 gram. Ultrasound wise, 11 centimeter is the cephalocaudate diameter. At least 3% of healthy people may have splenomegaly. Moderate if the largest dimension is 11 to 20 centimeter. Severe if the largest dimension is greater than 20 centimeter. By weight also, if it's more than 1,000 gram, it is considered as massive splenomegaly. What are the functions of spleen? This we all know, mainly reticuloendothelial system and all that. Grading, again, I told you, normal, grade 2, palpable just below costal margin on deep inspiration, 3 below costal margin but not projected beyond a horizontal line halfway between costal margin and umbilicus. All right, grade 4 is approaching the umbilical level but does not cross that horizontal line. 5 is palpable and it also halfway between umbilicus and symphysis pubis. And 6 is lowest palpable point beyond lower limit of grade 5. This is how it is. Very important, spleen versus kidney. All right, notch, no notch, can cross midline, generally does not cross midline. You can't get above, you may get above the swelling. Moved out on inspiration, does not move with respiration. Not ballotable, it is ballotable. There may be a rub sometimes, which is very rare, but no rub as far as kidney is concerned. Okay. Trabe's space is the most important thing to percuss, and you should know left anterior axillary line, 6th rib, costal margin. This should area be resonant on percussion. If this is dullness, if it is dull, then indicates splenic enlargement. This is what it is. Okay. Ben Kessel's method. Yeah. Percuss in the lowest lip intercostal space in the left in the anterior axillary line, usually 8th or 9th space. This space should remain resonant during full inspiration. Dullness on full inspiration indicates possible splenic enlargement over a positive Kessel sign. The other method is Nixon's method. All right, put the patient in right lateral decubitus. Begin percussion midway along the left costal margin. Proceed in line perpendicular to the left costal margin. If the upper limit of dullness extends more than 8 centimeters above the left costal margin, this indicates possible splenomegaly. If the upper limit of dullness extends, if the upper limit of dullness extends more than above the left costal margin, this indicates possible splenomegaly. This is how it is. Light lateral decubitus. Again, how does spleen get enlarged? Either reactive reticuloendothelial hyperplasia, lymphoid hyperplasia, proliferation of lymphoma cells, infiltration by abnormal cells, extramedullary hematopoiesis, proliferation of macrophages, and vascular congestion. Symptoms and signs are generally, you all know, we've already talked about that. Again, main causes, like we talked about, liver, either infective, hyperplastic, congestive, or infiltration. Infective are all these. You all know with TB or malaria or Kala-Azar or even shortly in typhoid, in infectious mononucleosis, viral hepatitis, CMV, AIDS, all these. Intrahepatic obstruction, extrahepatic aortal hypertension, chronic congestive cardiac failure, hyperplastic extramedullary hematopoiesis, reticuloendothelial hyperplasia like spherocytosis, hemoglobinopathies, thalassemia, paroxysmal nocturnal hemoglobinuria, all these leading to hemolytic anemia, infiltrative malignant like lymphoma, CML, angiosarcoma tumor, metastasis benign can be storage disorders, amyloidosis, Hurler syndrome or cystic fibromas, hemangioma, hematoma, eosinophilic granuloma, disordered immunoregulation like sarcoids, SLE, rheumatoid arthritis, collagen disorder, immune thrombocytopenia. Massive generally you see in myeloproliferative disorders, chronic malaria and Kala-Azar, storage disorders, thalassemia major, sarcoidosis, Gaucher's, hairy cell leukemia, diffuse splenic hemangiomatosis. Moderate you see in cirrhosis, lymphoma, amyloid, splenic, abscess or infarct, hemolytic anemia, and infectious mononucleosis. Mild in acute infective conditions like typhoid, Kala-Azar, malaria, septicemia. Some special situations, again, same, leukopenia, Felties or septicemia, pulsatile spleen, aneurysm, jaundice, cirrhosis or hemolytic anemia, like that. Lymph node enlargement, part of peripheral immune system, consists of B cells and T cells, site for immune cell contact with antigen leading to activation of immune response and elimination of antigen, increase in immune cells during antigen response, all right, infiltration by inflammatory cells, malignant proliferation of lymph node cells, metastasis, or infiltration by metabolic-laden macrophages. If it is more than 1 centimeter, except in guanal where more than 2 centimeter enlargement is needed when you say it is a significant lymphadenopathy. Again, factors to consider is physical characteristics, nodal location, clinical setting, supraclavicular, all these sites are even important. All right. So these are some important things I wanted to tell you. And if you have any questions or comment, please go ahead and write in your chat box. So if you have anything, please write in your chat box. I'm not seeing any questions from you in the chat box. Can you all hear me?
Yes, sir. Yes, sir.
Any questions or comment anyone has, any queries one has before we wind up? Niti? Yeah, go ahead.
Uh, Sir, can you check the question box as well, sir?
Yeah, just a second, hold on. Niti? 10 मिनट में आना आप लोगों पर। और एक वो मेरा सिस्टर का वो मंगाया नहीं मेमोग्राम, हाँ सब हो गया, तैयार पड़ा है, मंगवाना सुबह ना जाए। Yeah, sorry, I'll see the questions also. Okay, yeah, there are. So, yes, they're written that there is GRD post-asthma, nasal drip, cause for dry cough, ILD. Yes, ILD, dry cough, very good. Pleural effusion can also produce dry cough, excellent. Pertussis, yes. COVID. How does the lung CA change the voice? It changes voice by involving recurrent laryngeal, one. Secondly, in SVC syndrome, this may happen with CA lung. All right, so it can cause vocal cord paralysis. So they say loss of 10% body weight in 6 months or loss of 5% in 1 month. That's the right definition, Swati. So if within 1 month, if you lose 5%, probably it is significant weight loss. Not the 4.5 kilogram in 6 to 12 months. I think that's not the right answer. Latest suggestion says 4.5% or 5% weight loss in 6 to 12 months. Latest means which edition? 20th?
Yes, sir.
20th?
Yes, sir. Yes, sir.
Okay. So I am subject to correction. Cervical lymph one node yet matted 12 to 15 centimeter, normal liver span 12 to 15 centimeter, 10 to 13 centimeter. In fact, most of the people say anything of this level 10 to 13 is right. 15 always is considered as enlarged. Hepatitis will present with fever. Absolutely right. But alcoholic hepatitis is one which may not present with fever. Cirrhosis में portal hypertension होता है. Yeah, I fully agree, Sparsh. Yes, this is very important. Will the cirrhosis have not reduced the liver span? Ideally, yes. But initial stage of this thing, you may still have a liver enlarged and a spleen also coming up and still have ascites. But generally, you would expect a reduced liver span when cirrhosis is set in. Why spironolactone is preferred over as in ascites? In general, this is a potassium retaining diuretic, so we don't want to give a diuretic which causes significant sodium and potassium loss both, and potassium loss may be catastrophic. So even in other cases also, many times, even in chronic congestive heart failure, we give a combination of potassium retaining diuretic and a furosemide, which is non-potassium retaining diuretic. Any other questions? Yes, please. Any other questions? Yeah, Valid?
No, sir, no questions.
No questions. Okay, so I hope you have learned at least something, what you could have learned on a real case scenario rather than learning on a virtual. Only biggest drawback is no direct patient interaction and no direct clinical examination. That's been definitely a big drawback. deficiency on this pattern. I hope some things are clarified, some things are. So I'll wind up and thank you all for your patient participation, and all the best to you.
Thank you, sir.
Okay, we'll sign off.